go to the test now. We have these 4 possibility. 4 heart sound, is a third out sound, is a gallop, or is an atrial septal defect. So let me share with you the test. And okay, I launched the test. You have 30-40 seconds to answer. So is a 4th sound, a 3rd sound, is a gallop, or is an atrial septal defect? So there is still someone that has to answer the test. So let's wait to complete the. So please make your selection, and okay, I shall stop now. And okay, this is the result of the test. The large majority of those that make the test were convinced among the 2 possibility, either 2 sounds, let's say, or atrial septal defect. So let's return now to the pulling, to the okay, let me, okay. So this is the explanation, and this is the phonocardiogram. Okay, let me explain what we have recorded. This is the first heart sound. This is an ejection murmur. Is ejection because it's diamond-shaped. It does not cover throughout systole. There is an empty space at the beginning. And this is a fixed split second sound with the aortic and pulmonic component. So this is a very nice recording of an atrial septal defect. So, okay, as you can see, there is ejection, murmur, first sound, and splitted second sound. So atrial septal defect is characterized by the fact that there is an equalization of pressure in the right and left atrium, and because of this, the pressure are equal, so no variation in the respiratory maneuver can be appreciated. And the second component of the second sound, that is the pulmonic component, is delayed because the overload of the right ventricle due to the shunt that will create an overload to the right ventricle, delaying the closure of the second of the pulmonic valve. So let's go on another test. So let's listen again. Please be concentrated. Okay, so 4 possibility: mitral regurgitation, aortic stenosis, mitral stenosis. I don't know. Let's go to the pulling. I launch the pulling now, and this is the test number 2. And please make your vote.
Oke, silakan teman-teman untuk menyentuh saja ya, atau kalau pakai mouse diklik saja di salah satu jawaban, maka akan di capture oleh sistem. We couldn't see the poll.
You don't see the poll?
Yeah, no, because I don't see the screen.
So now it's in?
No, I don't think so. I think you don't share anything. I couldn't see.
I have the results of the test.
But
I have in front of me the results of the test.
Yeah, but not appear in the screen.
Okay, let me understand what. Okay, I have the share results now.
Okay, yeah.
Okay,
it's clear. It is clear.
Yeah, because I was waiting for the end of the sharing.
Okay.
And so we have that the vast majority was voting for mitral regurgitation, someone for mitral stenosis and aortic stenosis, and I don't know. Now let's make comment. So let's return on the slide just in 1 second. Here it is. And so is mitral regurgitation. Is mitral regurgitation because the murmur is systolic here, first sound and second sound, could not be mitral stenosis because in that instance the murmur would have been diastolic. And the other concept is that this is a regurgitant murmur, is very different from the aortic stenosis. When we should speak about aortic stenosis, I shall emphasize the difference between the two murmur. So the explanation is mitral regurgitation. So let me show you the same recording as before, but with the phonocardiogram impressed on it. So I show you another time. Okay, so now we can move to the lesson on mitral regurgitation. Please allow me a few seconds to move from one file to another file. Just a few seconds.
Okay.
I don't know, Dr. Renan, if you want to make comments in the meantime, but I am almost ready to start. So when you want, you can start with the lesson.
Okay, once again, my colleagues, teman-teman, please use your headset or earphone to make it clear. Sekali lagi, program ini adalah program lanjutan buat yang baru bergabung dari program kita minggu lalu. Ini adalah acara dalam rangka ulang tahun Rumah Sakit Jantung Harapan kita, Departemen Kardiologi dan Kedokteran Vaskular FKUI dan PP Perki bekerja sama dengan support kita dari Daria Faria. Terima kasih Daria Faria untuk kontribusi yang sangat luar biasa untuk acara ini. Okay, please you can start, Professor Iliseto.
Okay, fine. So the lesson number 1 today will be mitral regurgitation. Mitral regurgitation is the object of increasing interest nowadays as aortic stenosis, because many years ago, the most frequent possibility for mitral regurgitation was rheumatic valve disease as for aortic stenosis. But nowadays, the degenerative etiology is becoming progressively more important as the one related to left ventricular dysfunction. So this is a classical phonocardiogram that highlights the concept of regurgitation and the concept of timing of murmur in order to be distinguished between aortic stenosis and mitral regurgitation. So let's spend together a few seconds to understand the pathophysiology basis of auscultation finding. So A is aortic stenosis, B is mitral regurgitation. So LA is pressure in left atrium, LV, pressure in left ventricle, aorta is the pressure in aorta. So in end diastole, you can see that left atrium, left ventricle will have more or less the same pressure. And when in systole, at the beginning of systole, the pressure in the left ventricle will become higher and higher, the mitral valve will close because the pressure will exceed the left atrium pressure. And as a result of the closure, the first heart sound is produced. Then, going up and up, the left ventricle will reach aortic pressure, thus opening the aortic valve that usually does not create a sound, with the exception of a bicuspid aortic valve, and we shall see something like that in the next lesson, next week. Then the pressure in the left ventricle and the aorta will be equal. Then left ventricle pressure will go down, 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 below aortic pressure. And this pressure difference will create the closure of the aortic valve and therefore the second heart sound. So aortic stenosis and mitral regurgitation are systolic events. In the first instance, the murmur is created by the narrowing of the aortic valve during the ejection phase, and this is why the murmur is named ejection murmur. In the second situation, the murmur is created in systole by the regurgitant fraction of output that will return in the left atrium, and that's the reason why the murmur is named regurgitant. In the first case, the murmur will end with the closure of the aortic valve, while in the second case, the murmur can continue for a short time after closure of the second sound. The main differences of the two murmurs are represented by two key factors. The first, as we shall see, is the site of auscultation. For the aortic murmur is aortic area. For the regurgitant mitral murmur is the mitral regurgitant area. And then also the quality of the sound is different. Is relatively hard for the aortic stenosis, relatively soft for the mitral regurgitation. So this is an echocardiographic example of a mitral regurgitant jet here in the lower left of a patient with poor left ventricular function. And you can see in the upper left, the left ventricle, in the upper right, the continuous wave Doppler, and here the color Doppler. So if we use a stethoscope, we have to perfectly understand, as I mentioned last time, that with the diaphragm and the bell, we can hear different findings. In the context of mitral regurgitation, the diaphragm will be used to appreciate the regurgitant murmur, and the bell for the third sound and diastolic rumble that are characteristics of severe mitral regurgitation. We shall return on this concept with clear example. Another aspect that must be kept in mind with mitral regurgitation is the irradiation of the murmur. Why the irradiation of the murmur? Because according to the direction of the jet, the murmur from the apex will be heard somewhere else. Let's return on this slide for a moment. So this is an example in which the regurgitant murmur is central. A murmur such as this one does not irradiate. A murmur such as this one is mainly heard at the apex. A murmur such as this one does not produce sound outside the mitral area. While in this case, the murmur, as you can see, is eccentric. In this case, it goes through the posterior part of the aortic root. This is a mitral valve prolapse with eccentric jet. And what happens in terms of auscultation is that the murmur that is betterly heard on D is irradiated through C and A. In other words, it goes through the posterior wall of the aorta. The irradiation of the murmur is due to the transmission of the murmur throughout cardiac structure, and it follows cardiac structure. So when you hear a murmur of mitral regurgitation, the apex, irradiated through the base of the heart, is very likely that is a posterior leaflet, flail leaflet, or mitral valve prolapse. This is another example in which the jet is directed through the lateral wall of the left atrium, here, eccentric, exactly in the opposite way as in the case before. And as a result, the irradiation is through E, F, G, that are the anterior, medial, and posterior axillary area. Dr. Renan, I should stop for a second in order to be sure that the concept of irradiation is well appreciated by our friends and to understand if there are specific questions on this. Immediately afterwards, I should start with auscultatory findings. So if you think appropriate, we can stop for a second and to proceed, or we can go ahead. It's up to you.
I think it's clear your explanation because it's very depending on the direction of the jet, right? I think we can skip this question answer later on. Just show us the
okay. So
the example.
Let's go ahead. So let's enter now in the more active phase. So this is an example of, we shall hear a different example of mitral regurgitation. So what I shall show you in this example, in many others, will be a dynamic construction of the murmur. You will hear, this is the phonocardiogram, 3 beats without the murmur, and then the murmur will appear. Of course, this does not happen in patient, but this is a electronic filtering of the murmur in order to facilitate the appreciation of the murmur when the murmur appears. So this is an example of a mitral regurgitation. You will appreciate 3 normal beats, and then the murmur, here you see, will appear. I can anticipate that the murmur is a systolic murmur, of course, because this is the first sound and this is the second sound. Diastole is without any kind of additional sound, and the murmur will be soft, as all the mitral regurgitation. let's make another round on the same test, the same sound. So now let me explain you a small trick, something that I personally do. When I perform cardiac auscultation uh, and I have murmur or anything that needs to be appreciated, what I do, and I suggest to my fellow, is to close the eye. When you are hearing, please close your eye, because this is something that is very physiologic. So those that are unfortunately incapable to see develop the capacity of auscultation very, very sophisticated. Because if you close your eye, your brain is completely concentrated on sounds. Please do this in your practice. Do this in your practice and you will appreciate better the sound. So let's do today all the example with the high close. Let me show again another time, and please concentrate on the first and second sound, first and second sound, first and second sound, and then the appearance of the murmur. Please put in your brain that murmur, because this is a very good example of soft regurgitant mitral murmur. Okay, so let's move to another example. So this is another example. As you will see in this lesson, D will be always present because it's the mitral area, and all the regurgitant murmur are systematically appreciated on the apex area. Then it can happen that they are irradiated, as in this case. So this case is radiated through the axilla. So this is an interesting case, and you will see again that the first 3 beats will be filtered. Then there is something new. A third sound will appear, and then the murmur will appear. So why I'm stressing the concept of the third sound? Because the third sound, as I told you in the previous lesson last week, is something that is physiological in kids, but is a sign of a pathological finding involving the left ventricle in adult. And the possibility are mainly two. Either that there is a dysfunctional left ventricle, as for example in myocardial infarction, and this is a very bad sign, or that the impact of blood on the left ventricle in early diastole is extremely important because of the overload, as it happens in mitral regurgitation. So when in mitral regurgitation you appreciate a third sound, is an indirect indicator of severe mitral regurgitation. So in this example, we shall listen the first in the first 3 beats, first and second, first and second, first and second sound, and then the third sounds will appear, and then lastly, mitral regurgitation. So I suggest you to do the following: to listen this example, watching the phonocardiogram that will help you in positioning in your brain different sounds. Then we shall redo the same recording without watching the screen, but with the eyes closed. So let's start with the the first modality, eyes open, watching the phonocardiogram. The third sound is a low intensity, low frequency sound. It's not like ta, it's like boom. It's low frequency sound. So please, let's do again, watching, and then we should do the same thing without having access to the phonocardiogram. So see what's happening and try to synchronize what you see with what you hear. So now let's do the same thing with eyes closed. So let's move to another example. And I hope that you have appreciated the difference in, making auscultation with the concentration that comes from having eyes closed. So this is another example built in the same modality. So we have electronic filtering progressively active. At the beginning, we have first and second, first and second, first and second. Here you have first and second, first and second, first and second. Then a third sound appear, and then the murmur will appear. So let's make the same story as before. Please appreciate what is present, and then we shall go on the second view without seeing. So this is another example, and we have again first, second, and okay, sorry. Here it is. This is another example, and we have this time 4 beats without murmur, and then the murmur will appear. Again, please do the test, do the auscultation appreciation, watching the phonocardiogram, and then without having a look to the phonocardiogram. Let's start. So in this case, I didn't mention before, we have a third sound appearing at the end. So you will have 3 phases in the construction of the auscultation. In the initial phase, you will have only first and second. Then you will have, here it is. Then you will have the murmur, here is, and then the third sound will appear. So again, we have a complete recording of mitral regurgitation built step by step. Then we shall appreciate in the next example something that is without electronic construction, but is a complete finding immediately. So let's make together this exercise before the next test, because the next example will be a complete example without filtering before. And I want to mention that we have normal sounds, then regurgitation appearing, and the third sound. So please do this without with eyes closed. First and second. Now murmur. And now murmur with a small sound, low sound, immediately after the murmur. I want to review with you just this part of the recording in order to maximize with you the meaning of this third sound. Okay, just a second. Okay. Okay, from this moment on, you will have mild regurgitation and the third sound. Please appreciate the low frequency sound immediately after the murmur. Close your eye and concentrate on that. So this example, before moving to other classical situation, evolving situation, this is now a very classical example of mild regurgitation murmur in a patient with rheumatic valve disease. The murmur is better heard on D apex and is irradiated throughout the axilla up to G, that is the posterior line of the axilla. This is a severe murmur with a third sound and all the aspects related to severe mitral regurgitation. Some are those related to what you listen during auscultation. The other are due to where you listen. Because if you listen something like this until G, it means that the left atrium is extremely enlarged. But if you put the two things together, the fact that is extremely enlarged because the murmur reach G line, and at the same time you have also the third art sound, the two things put together are the expression of a very severe mitral regurgitation with the enlargement of left atrium that is the effect of a severe mitral regurgitation. So before I start, please appreciate here the first sound, the regurgitant murmur, the second sound, and the third sound. So let's listen this example with the eyes open, and then we shall close the eyes in order to better appreciate the third sound especially. So let's listen now with eyes closed, and you will appreciate the third sound, I think, more easily. But please be concentrated. The next one is another example that has something a little bit different. This is difficult, but I have to explain also the difficult things. Here you have the first sound, the second sound, the mitral regurgitation, then the third sound, and then a small murmur after the third sound, a small low frequency murmur, and this is called relative mitral stenosis. So in other words, there is no mitral stenosis, but the amount of blood that crosses the mitral annulus because of the important regurgitant murmur exceeds the normal entity that should pass through the annulus. And as a result, this low frequency murmur is produced. That is like a mild aortic mitral stenosis. So let's see the murmur having access to the phonocardiogram, and as usually we should make the same thing without watching the phonocardiogram. I show you again. I hope that you appreciate the fact that after the third sound there is a small murmur, very short, low frequency, different from the regurgitant jet. So now we shall listen a special electronic construction, and we shall appreciate, as usually, 3 beat without murmur. Then the regurgitant murmur will appear, and at the end, the third sound with the low frequency murmur following the sounds will occur. This is an example of a severe mitral regurgitation because there is a third sound and the small murmur after the third sound. So let's please watch everything before having access to the sound without watching, but with the closed eyes. So open, have a look, and then without having a look. So we are now close to the end, and then we shall devote time to question and answer. So this is an interesting example of a very particular mitral regurgitation. And we have an eccentric jet. This eccentric jet is well irradiated, but is different from other mitral regurgitation for something that you will see immediately in a moment. So the murmur does not cover systole, is concentrated in systole. What produces something like this? Mainly 2 situations. One is mitral valve prolapse, that is the next lesson. The other one is dysfunctioning mitral papillary muscle in ischemic heart disease of acute myocardial infarction. And this is something that is typical of ischemic heart disease. And when you listen something like that in a patient with ischemic heart disease, you have not to be worried about the mitral valve, but you have to be worried about the left ventricle. So let's listen this jet, watching the phonocardiogram, and then we shall review it with closed eyes. So please be concentrated, because you will hear the first sound, the empty space, and then murmur and second sound. This means that the murmur does not cover entire systole, but is end systolic. The end-systolic murmur can be the result of mitral valve prolapse of ischemic heart disease. Of course, this is something that is very easy to be understood according to the medical history, the patient age, the patient appearance. If you have a young person, young female with a murmur such as this one, you have no doubt mitral valve prolapse. If you have an old man with risk factor, with chest pain, hospitalized for myocardial infarction, it's not mitral valve prolapse, it's a dysfunction of the papillary muscle. So let's listen now with closed eyes. And now we go to the last example. The last example is a mitral valve that is stenotic and regurgitant. So this is an example of mitral stenosis with mitral regurgitation. And just to show how the things are, you will have, of course, it seems complicated, but this is what happens. This is the first sound, regurgitant murmur, second sound, opening snap, diastolic murmur that is low frequency. You can see that the intensity on phonocardiogram is different here, 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 and here, if compared to this area, and this area. This is the result of intensity of the sound. The higher intensity is the higher is the signal tracing. And this is what happens in systole. This is what happens in diastole. That's the reason why this systolic murmur is better appreciated than the diastolic murmur. So you have to be concentrated and you will listen a complete mitral stenosis and mitral regurgitation, which is not uncommon in a patient with rheumatic valve disease. So I shall show you this a couple of times watching, and then a couple of times without watching the tracing. This is a complex recording, but this is real life, is what you will find in a patient with rheumatic valve disorder affecting the mitral valve. So let's start. So we have two murmur. One is soft, high intensity. The other one is the regurgitant. The other one is woo, woo, is the diastolic murmur. Putting together, you have boo, boo. That means that you have regurgitation and stenosis, regurgitation and stenosis. So let's listen again, watching, and then 2 times without watching. And now, please close your eyes and concentrate on the sound. Oh, sorry. Another time with the eyes closed. Okay, so I think that now it's time for question and answer, Dr. Renan. And I want to underline a few concepts just as a reminder.
Yeah, there are lots of questions here.
Okay, so
Okay.
let's go ahead. I'm ready to answer.
Okay, this is, I think you will have another session with ventricular septal defect, right? Because the question is how to differentiate murmur in MR and VSD.
Okay, okay, I can give the answer immediately. And okay, and we shall return on this in the last lesson, but let's make just something immediately and quick for our friends. Just a second. Okay. So let's take this slide, for example. So usually, of course, is usually, if you have a mitral regurgitation murmur will have the maximum on D. Also, ventricular septal defect will have more or less the maximum in the same area. The difference is that ventricular septal defect will irradiate through H, exactly in the opposite direction than the mitral regurgitation. So mitral regurgitation can irradiate in this area. Sometimes no, simply concentrated here, but not very frequently it goes in this direction. On the contrary, ventricular septal defect is irradiated through H, sorry, that is the right ventricle area, auscultation area. So the answer is take care about the irradiation.
Irradiation. So the same question. Let me give. There's complex situation in which there will be the tricuspid regurgitation also present.
Okay, tricuspid regurgitation will be completely treated in on the fourth
costal. Yeah.
But just to give a very quick comment, tricuspid regurgitation will be recognized thanks to the so-called Rivera-Calvaro maneuver.
Yeah.
I will explain what the Rivera-Calvaro maneuver is.
But you will talk about that when you're discussing tricuspid regurgitation later on, right?
Absolutely. Last session.
Okay. I think we can skip that right now, because there are lots of questions. There's another question also. If there is a murmur in one point of location, how do you know that it's original location or the radiation from another location? Interesting.
We have to consider that auscultation is like a tailored dress. In other words, it's something that is to be adapted to the patient we have. So the rule number one is to identify the area of maximal intensity, and then to understand where the murmur is irradiated. In the majority of instances, the maximum intensity area is coincident with the typical, let's say, auscultation area of the specific funding. Let's put this that help us. So let's suppose that you are dealing with mitral regurgitation. In the majority of instances, the maximum intensity is on D, and then there is the irradiation. Sometimes it's not rare. If there is a flayed leaflet, for example, of the posterior leaflet of the mitral valve, as I show you, the irradiation is through the posterior wall of the aorta, and therefore goes to C and A. So this is not rare. What can happen is that for some reason, the maximum is not any longer here, but is here. But this is not the area of mitral valve auscultation in terms of maximum intensity, but it can occur. And we are helped in that instance by the quality of the sound. Because a systolic murmur that is very strong here and less here could even be a systolic ejection murmur. Like, for example, in hypertrophic obstructive cardiomyopathy. But the type of the murmur will help us. So we have to consider always two entities that are where is the maximum intensity, but we have not to forget the quality of the murmur, the type of the murmur. And when next time we shall discuss about aortic stenosis, and I shall show you side by side the difference between mitral regurgitation, aortic stenosis, being both systolic murmur, it will become even more clear, this concept.
Okay, this is a question about the situation that you saw us before, in which there are severe mitral regurgitation, and at the end, then we will hear the diastolic murmur. So the question here is, how do you differentiate between the murmur of mitral stenosis? Because it sounds like it was early diastolic murmur. How to differentiate that? That first question. The second question, if how do you sure that that's because of true mitral stenosis or because of um, relative mitral stenosis due to high volume at left atrium?
This is a good question. I thank the colleague that posed this question. And the difference is due to the auscultation of the diastolic rumble, the diastolic murmur.
Yeah.
If is a mitral stenosis, the diastolic murmur covers the entire diastole. It goes from the beginning to the end, because the stenosis is present throughout the diastole. In the so-called accompanying murmur, a murmur that accompanies another murmur, the relative stenosis occurs only in the first part of diastole, when the blood that goes in the left atrium returns in the left ventricle, and so the diastolic low frequency murmur, the rumble, is extremely short, attached to the third sound. So the difference is in the length of the murmur.
Yeah. Okay. Can I hear the opening snap sound if there are mitral regurgitation and mitral stenosis appear together? I think you saw it, right? There's
yeah, and then of course the opening snap that
snap,
is
you heard that
sound, because the opening snap is high frequency murmur. Yeah.
Yeah.
The frequency sound.
Yeah, I think Professor Elisa, there are lots some question also, mostly coming from our colleagues and cardiologists. Is that really true that we cannot differentiate the severity of, at least we cannot guess the severity of the mitral regurgitation only by hearing the auscultation only? But you saw us there are another educated guess to at least think that this is a mild or at severe mitral regurgitation.
So this is true. While aortic stenosis gives us some elements that we shall discuss connected to the severity of the disorder, for mitral regurgitation, I agree, there are no strong element. However, there are auxiliary elements. For example, if we have the third sound, it means that it's important. If you have irradiation to the axilla, it means that there is important left atrial enlargement, and this is another element. And the third element that is not auscultation, but is physical examination, is that when you have a mitral regurgitation that is severe, as a rheumatic disorder, is different if you have a cardiomyopathy. If you have a rheumatic disorder with important mitral regurgitation, you have something that is very old but is important, is the pulse below the finger at the apex, because the apex is exaggerated in his movement because there is the overload. And so if you have the pulse, the third sound, and the radiation, this means that there is a severe mitral regurgitation. If the severe mitral regurgitation occurs in a patient with dilated cardiomyopathy or myocardial infarction, you don't have either the irradiation, because the jet is central, and then you even lose the pulse, because there is poor contractility. The pulse below the finger is the expression of the left ventricular overload. That means a lot of blood ejecting with force because you have a good left ventricle, that is the good ventricle of rheumatic disorder. But if the mild regurgitation is severe and the result of the poor contractility, you miss this.
Okay, thank you very much, Professor Liseta. It's very clear explanation. So I'll talk in bahasa. Jadi teman-teman sejawat, kita bisa membedakan, melakukan educated guess untuk tahu ini pasien severe mitral regurgitation apa tidak, dengan melihat tadi tanda-tanda secondary axillary, Prof menyebutnya adanya S3 gallop ya dan lain-lain. Kemudian kalau kita mendengar irradiate ke arah aksila, posisi DEF ya, yang ke samping tadi ya, yang ke arah aksila, baik aksila linea aksila anterior, mid atau posterior, itu salah satu tanda yang harus kita pertimbangkan ya. Dan kemudian tadi lagi pulse ya. Dan ada pertanyaan tentang bunyi jantung 2, membedakan dengan itu apakah S3 gallop atau split pada bunyi jantung. Jangan lupa bahwa kita tidak hanya pada satu posisi. Anda pindahkan dari kuliah pertama, pindahkan ke posisi AB, dan akan appreciate nanti di posisi aorta dan pulmonal terutama, di situ split, dan kemudian kita perhatikan persistensi dari fixed splitnya. Jadi bukan hanya mendengar di satu sisi saja ya. Baik, alright, Professor. I think we can. This is the middle part, right? So
okay.
Okay.
So
then,
I have my coffee. 5 minutes for my coffee. Okay. Okay. I come soon. I have a coffee, and in 5 minutes I'll be back. So be with our friends. Ask you 5 minutes for a coffee.
Okay.
Thank you, Dr.
Thank you. See you again. See you in 5 minutes. Okay. Baik, teman-teman, kita punya break 5 menit. Ya, sambil break, pada kesempatan ini kami ingin menyampaikan teman-teman bisa lihat, kita ada sampaikan klip ya, klip lagu salah satu yang kami tampilkan ketika ulang tahun Departemen Kardiologi dan Kedokteran Vaskular beberapa hari yang lalu, ulang tahun kita, dan kita baru saja kehilangan salah seorang pionir Departemen Kardiologi, Dr. Ote J. Rahman, salah seorang pendiri Rumah Sakit Jantung Harapan kita, dan juga pionir bidang kateterisasi di Indonesia ya. Teman-teman bisa dengar lagu yang kita persembahkan untuk beliau. Sambil istirahat, silakan ngopi, nanti kita kembali 5 menit lagi. Terima kasih.
Surrounded by the fibrous ring, directly connect to the aorta. The mitral leads grow from the LV, the smiling fall, surrounded by the fibrous ring, directly connect to the
Dari sebuah kecintaan akan gagasan, gairahkan semangat untuk bekerja keras. Lahirkan karya bermutu dan berkualitas tinggi. Dari setiap detail inovasi yang dilakukan, yang mampu hidupkan mimpi. Hadir nyata melintasi masa, membentang ke penjuru negeri, yang membawa perubahan berarti di dunia farmasi. 1976, Daria Varia resmi didirikan sebagai perusahaan farmasi. 1978, menjadi produsen pertama kapsul gelatin lunak di Indonesia. Dan di 1994, terus berkembang menjadi perusahaan terbuka. 2001, berafiliasi dengan perusahaan farmasi terbesar Filipina, United Laboratories Incorporated. 2012, mencapai angka penjualan sejumlah 1 triliun rupiah. 2016, di usia 40 tahun, Daria Varia tetap berkomitmen untuk Indonesia yang lebih sehat. Daria Varia berdiri teguh di bentang industri farmasi Indonesia. Menghasilkan produk berkualitas melalui 2 manufaktur kelas dunia yang berada di Gunung Putri dan Citerep Bogor. Pabrik Gunung Putri menghasilkan produk kapsul gelatin lunak, cair, krim, dan lotion. Dan pabrik Citerep memproduksi produk injeksi steril dan sediaan padat. Semua produk diproses sesuai cara pembuatan obat yang baik, didukung oleh teknologi yang modern, dan sumber daya manusia yang kompeten, profesional, dan ahli di bidangnya. Pengembangan fasilitas pembuangan limbah merupakan wujud nyata kepedulian kami terhadap lingkungan. Kami sangat memperhatikan kualitas bahan baku, proses produksi, quality control yang ketat untuk memastikan produk yang berkualitas tinggi hingga ke tangan pelanggan. Fokus kepada kepuasan pelanggan menjadikan Daria Varia dipercaya memproduksi produk berbagai perusahaan-perusahaan farmasi lokal maupun multinasional terkemuka dan mengekspor produknya ke berbagai negara di ASEAN dan Timur Tengah. Daria Varia untuk Indonesia yang lebih sehat.
Listener, are you already having your cappuccino?
Yes, yes, thank you.
So, what is your favorite? Talking about coffee, what is your favorite? Cappuccino or frappuccino or latte?
No. My favorite is Italian espresso.
Espresso, wow.
Espresso is the short coffee that is like a bomb. So short coffee, espresso is what it is.
But everybody loves cappuccino. Every time we came to Italy, just last time we visit Padua and Venice, then the truly cappuccino from Italy.
Okay, so I look forward to offer a cappuccino when you make it. Okay. I promise you. Okay.
Let's start.
If you want, we can start.
So you can start. I think.
Okay, fine.
This for the sake of our time, please.
Okay, sorry. So we shall start with the test as usual, and we have now three tests, test number 3, 4, and 5. Let me just check something very quickly. Okay, so let me, okay. Just 1 second. Okay, fine. So we can start with the, okay, this test that I'm going to share with you. Okay, as usual, I shall show you the sound first, and we shall move to the test afterwards. So, number 1. So these are the 4 possibility is mitral stenosis, aortic regurgitation, mitral regurgitation, atrial septal defect. Let's listen together again. So we can go now to the pool. I go to test number 3. I think that now you can see and you can vote. So 40, 50 seconds to make voting.
Oke, silahkan di touch screen aja teman-teman. Nanti akan otomatis akan muncul apa namanya.
So I've received almost 40% of voting. Please go ahead.
Oke, yang lain silakan tolong di touch saja screen-nya atau pakai mouse ya.
Okay, I think that we can stop now, even if I should wait, because there is still someone that has not yet voted. But okay, I finish and I share the results. And mitral regurgitation was the most voted, much more than the other. And more than 50% voted this. I'm happy about this result because the same test reshaped in a different way produce a much lower result for the mitral regurgitation. And this is a mitral regurgitation and was correctly identified, as you can see. And okay, this is very likely the results of the discussion we had before. Let me show the test watching the tracing, and you can see that we have first sound, second sound, and mitral regurgitation. So let's move now to the next test. The next test, here is the recording. So it is a low frequency sound, is not so strong as the previous one, that was mitral regurgitation. I show, pay attention because it's low frequency. Okay, let's move to the test. I share with you now the pulling. I go to test number 4 and I launch pull. So you have 4 possibility: mitral stenosis, aortic stenosis, mitral regurgitation, and mitral valve prolapse. And okay, you can go ahead and let's wait the next 40, 60 seconds for voting from everyone. Please vote. We have still some colleagues that have not voted. Okay, so this is the result. And as you can see, we have 2 head-by-head possibility: mitral stenosis and mitral valve prolapse, and then aortic stenosis and mitral regurgitation. So I shall not make comments now, but with the tracing, I should explain why is one possibility and why it cannot be the other 2 possibility. So let's return on the tracing, and I share with you. Okay, so this is the phonocardiogram, and as you can see, we have a first sound, a second sound, an opening snap, diastolic murmur. So this is mitral stenosis. It cannot be mitral valve prolapse because the auscultatory finding is in diastole. It cannot be mitral valve prolapse because the auscultatory finding is a low frequency sound, while mitral valve prolapse will be different and high systolic, high frequency, and systolic is the topic of next lesson. It cannot be aortic stenosis because it's a diastolic murmur, is a diastolic murmur, while aortic stenosis is systolic murmur. It cannot be mitral regurgitation for the same reason. So let's go now to the test number 5. This is difficult. So we have no murmur, just an extra sound. Let's listen again. No murmur, an extra sound. We have 3 sounds. So we have 4 possibility: is a third sound, is an atrial septal defect, splitting of the second sound, is a fourth sound, or is a mitral valve prolapse. So let's start with the pulling of the test number 5. Please vote. So this is the results, and as you can see, the majority vote for third sound. This is interesting result, and I shall explain you what I shall do in a moment, because, okay, sorry, this is the result, and it's very interesting. The majority vote for third sound, and since we are going to speak about mitral valve prolapse, I shall make a very quick modification of my lecture, because I want to explain you why this is a mitral valve prolapse and not a third sound. So let me go on the recording again, and you will see now the recording, and you have a first sound, second sound, and click. The click is the sign of mitral valve prolapse, but I understand that this can create a problem in the differential diagnosis, and that's the reason why I should make a slight modification in my presentation, that is mitral valve prolapse. I shall ask Dr. Renan a few minutes to make a small modification, because I want to insert an auscultatory finding in my presentation in order to facilitate the diagnostic differential diagnosis. Let's go ahead with the recording. So this is a click, and this could not be a third sound for two reasons. First, because the systole should be extremely short. If this was just systole and this all diastole. Secondly, because as you will see with the comparison, the third sound is low frequency sound, while the second sound is a high frequency sound. And in this differentiation, the utilization of diaphragm and bell will be extremely useful, because the bell will emphasize the presence of a third sound, and pressing the bell, this will disappear. So let me show you this again, and then I shall add one slide to my presentation to maximize the differential diagnosis. Let's go ahead. So there is no doubt that this finding is characterized by three sounds, and I understand that there is the possible confusion between the meaning of these two. While this is first sound, the other two could be either second sound and third sound, or click and second sound. Different reasons help you to understand that the reality is second sound and this is click. So Dr. Renan, allow me a couple of minutes, because I add something to my presentation in order to facilitate. So
okay, please.
Allow me really a few minutes.
Saudara sekalian, memang ini bagian yang tidak mudah ketika mengenali klik ya. Klik itu high frequency, ya, dengarnya pakai bell, tapi kadang-kadang memang susah membedakannya dia apakah menjadi bunyi jantung 3 dan sebagainya. Tapi nanti akan ada lecture berikutnya dari Prof. Yusuf akan memasukkan bagaimana kita bisa mengenali dengan baik klik ini ya. Tadi salah satu kuncinya atau salah satu clue-nya, triknya adalah dengan memainkan antara bell dan diafragma. Jadi untuk mendengar klik kita pakai bell, kita lihat, kemudian kita di press. Kalau kita ingat lecture pertama beliau minggu lalu, kalau kita press lebih dalam bell, dia akan jadi seperti diafragma. Maka suara klik yang high frequency itu, high pitch, itu akan berkurang, akan hilang. Ini salah satu triknya untuk memastikan bahwa itu adalah klik atau bagian dari hard sound. Ya. Saya sambil melihat pertanyaan yang masih tersisa. Ini sudah jawab sebagian besar ya. Jadi membedakan antara MR dengan MS ya. pada MR dan MS, kemudian MS yang true mitral stenosis dengan yang akibat dari high volume pada left atrium sehingga menyebabkan relative mitral stenosis. Kemudian bentar. Ya, ini juga oke. Nanti tentang membedakan antara ejection click dengan click split. Okay, please, Professor.
So we made I made a short modification that will facilitate this diagnostic differentiation. Okay, so let's start with the mitral valve prolapse. This is a very interesting chapter of cardiology. And I pay a lot of attention to mitral valve prolapse for different reasons. First of all, because it is a very interesting disease. There has been a lot of confusion in the past, still nowadays. Is the object of important research in Padova, but above all, there is a personal reason that I explain you in a very short moment. As you know, mitral valve prolapse was firstly described by Professor Barlow. No, Barlow is also called Barlow disease.
Oh, so Barlow is from Padua, right?
No, Barlow was a professor from South Africa.
Oh, South Africa, yeah.
From South Africa, from Pretoria, not far away from Johannesburg. He was. Let me tell you something. He was. He discovered mitral valve prolapse in 1966, so half century ago. He was a very, very distinguished professor in South Africa. He was a big expert of cardiac auscultation, and his favorite fellow was a person named Paolo Rizzon. Paolo Rizzon was Italian. He was from Padova area, and he was my teacher.
Oh,
and so,
really? Wow.
My teacher was the fellow #1 of Professor Barlow.
Professor Barlow, yeah.
So Professor Barlow, from the academic point of view, is my grandfather. So my father was
the grandson of Barlow.
Yeah, and so that's the reason why I joke about that. Barbara, that is with us, Barbara Hildebrand, my assistant, knows about the story, and I like to tell about this story. So it's a very interesting. So I spend almost my life in making research on mitral valve prolapse.
Oh,
and one day, Dr. Renan, if you like, we can share with our Indonesian friends. I can tell you which my vision of mitral valve prolapse is. Today we have to concentrate on the auscultatory finding, and I can tell you, even if we shall have no time, that the presence of the click in mitral valve prolapse is the expression of some morphofunctional alteration that are representative of the higher risk of arrhythmias. So I shall have no time to discuss this today, unfortunately, because I have to concentrate on cardiac auscultation. But if you like, one day we can share with our friends all my history with mitral valve prolapse and what in the time has been discovered, especially in Padova in the last 4 or 5 years, using cardiac magnetic resonance in mitral valve prolapse. So, having said this is a typical echocardiographic example of mitral valve prolapse. You have a very nice billowing of the posterior leaflet, and I shall not discuss these things, but one day perhaps I shall explain that the most important finding in mitral prolapse is this movement that is called curling. And curling is the results of an abnormality of the anatomy of the mitral annulus that creates this abnormal movement. And this abnormal movement create also other problems that will produce, in severe cases, arrhythmias, sometimes lethal arrhythmias. So this is what I was explaining before. So this movement occurs because of this annulus disjunction. And in the ears, this has been considered the most typical sign of mitral valve prolapse. Anyone that is older than a certain age and has used a mode echocardiography knows that when something like this is recorded, the diagnosis of mitral valve prolapse is 100% sure. And one day I should explain you that for years we have been convinced that this is the mitral valve prolapse. This is not true. This is the expression of this abnormality. And there are a lot of things that we have to learn about this. On the contrary, magnetic resonance is extremely sophisticated because it gives us the possibility to understand that there is this enlargement of the left atrium. And above all, this discontinuity of the annulus that is difficult to be appreciated by echocardiography because echocardiography is here it is. This abnormality is the key factor for understanding everything in mitral valve prolapse. So in these images, we have a nice recording, prolapse of both leaflets, mitral regurgitation, and this abnormality. This abnormality is better seen here with the prolapse and the annulus that is enlarged. So mitral valve prolapse, it can be characterized by mitral regurgitation. We shall discuss about this. And mitral regurgitation is almost systematically eccentric. This means that the murmur, if present, can be irradiated either through the posterior wall of the aorta and therefore through the base, or through the lateral wall of the left atrium, and because of this, through the axilla. So let's concentrate now on auscultatory findings. And as you can see, Dr. Renan,
Yes.
I'm enthusiastic about the extreme of cardiology. From one side, the auscultation, the other side, the very sophisticated method like magnetic resonance. Okay, so let's start with this auscultatory finding in this patient with mitral valve prolapse. And here you will see that we have 3 normal beats, and then the click here will appear. Because the click, let me tell you something to our friends, is the pathognomic sign of mitral valve prolapse. When mitral valve prolapse was identified by Professor Barlow, it was named the click syndrome, because at the beginning, the diagnostic marker was the click. And the click is the results of tension of the mitral leaflet when they go in like this, in this protrusion. When they protrude, like here, they produce a click. A click is when it goes up, up. This tension will produce a sound that is high frequency non-ejection click, a mid-systolic sound. So at the beginning, Professor Barlow identified patient thanks to the click. And that's the reason why it was called click syndrome. If the click is identified, the possibility of the presence of mitral valve prolapse is extremely high. Today, I have no time to explain why the click is the expression of the most severe mitral valve prolapse from the arrhythmic point of view. But I hope that one day we shall have this opportunity. So let's start now with the auscultation, and we shall listen a click appearing after 3 beats. Please put your earphone and be concentrated. So this ejection click is a click that is present in mid-systole, and that's the reason why it's called mid-systolic click. So returning to the doubt that arise from the test, I voluntarily prepared that test to try to understand which was the perception from our colleague in terms of 3 sounds that are present. So because immediately someone thinks to the third sound, but now we have to try to understand together how to distinguish a click from a third sound. So let's start again, but please close your eye and listen with attention. Okay, so keep in your brain, keep in memory this rhythm and this sound, because in a short while I shall show you in a moment a third.
Professor Illustrator, could you repeat, because we can hear only one cycle and click, and the others cannot hear well. Couldn't hear well. Okay, you just repeat once again this song.
Okay, so okay, I have this. This is better. Okay,
Yeah.
let's listen this one together. Okay.
Yeah,
It's
seems
okay.
to me no sound when you move this side.
Okay, let me do something. So you don't hear the sound?
Especially if the last part of the cycle.
It's okay?
No, no. What happens? Once again, could you repeat? No. So the sound became decreased. We can hear it only once or two times, and then the last slightly decrease.
Oh, it's very strange. Okay, let me reload the file again. Just 1 second. So I just want to check if it is a matter of a slide. Okay.
Let's say in the entire cycle, half could heard well, but not but half the last half.
Okay. Let me.
There's the lost song.
Okay, let me just this example. Let me know, and then we start again. Okay, I'm sharing with you another case, just to be sure that is something that is related to. Okay. Okay, let me. Okay, if I show you this, what happens?
Okay. This is clear. And
Okay. So perhaps was on. So this is clear.
Okay, clear.
Okay, so let's return to the previous one. Hopefully, okay. Let me so. Okay, let me. Okay, so let's start again with this one and tell me if you hear or not. Does it works?
Yeah, I think yeah.
Okay, so let's return on this case. Now I'm going to show you two normal sound, first sound and second sound, then the mid-systolic click will appear.
Okay.
Okay, so again, as usually, let's watch the tracing and listen, and then we close our eyes and we go ahead without watching the tracing. Normal sounds, normal sound. Click now. So was
Okay.
heard? Okay.
Yes, yes.
Now you can appreciate, dear colleague, we have the first sound, the second sound, and in the middle, the click. And then we have empty diastole. And the equilibrium, I should call, between the length of systole and length of diastole does allow us to understand that this is the second sound and this is the click. Now I want to spend time with you on the differential diagnosis of two different situations that produce three sounds that theoretically could be confusing. But I need to explain you how to differentiate the two situations. And again, I explain you that here we have first sound, click, second sound. First sound, click, second sound. Now I want to show you again. And this time, please close your eyes, concentrate, because the next example will be first sound, second sound, and third sound. But I need to help you in understanding this. Okay. Okay, it's clear?
Yeah, again, this, the last part couldn't hear well, but some of click already heard 1 or 2 times.
Okay, but let
Okay,
me...
but it's okay. But it's okay. We can hear some of the clicks from this.
Okay, well, let's listen again. This from this part.
I can hear. No sound. No sound. No sound.
Okay, something does not work in the tracing, but the important is that you have appreciate first sound
Yes.
and second sound. So let's move now to the third sound. Here is an example of third sound with 3 normal beats, and then the third sound will appear. So we have first, second, first, second, first, second, first, second, third, first, second, third. So the first thing that I want to show you is that the equilibrium from systole and diastole should be kept in mind. But we shall discuss this later on in a moment. So please appreciate the different rhythm and the different balance between sounds, being the last one, the third sound, low frequency sound. Was okay?
Okay. Okay.
Let me show another time. Okay, so let's stop for one moment with tracing, because I need to explain how to differentiate, because this was a problem that arises from the test. I'm not surprised.
Yeah.
I'm not surprised about that. So how to differentiate two different rhythms with 3 sounds. So let's call possibility number 1 is that is first sound, second sound, and third sound. Possibility number 2 is that is first sound, click, second sound. So first of all, we have to consider the environment, because the third sound in an adult patient is systematically the expression of a severe left ventricular disease. And so the clinical history will help us a lot. And we should put that auscultation within the medical evaluation of the patient, because very likely that patient will be a patient with heart failure symptoms, will have enlarged left ventricle, will have a disease affecting left ventricular performance, like dilated cardiomyopathy or ischemic heart disease, or even myocardial infarction. So the clinical environment. On the other hand, if there's a click, we shall have a teen person, perhaps young, female, with arrhythmias, anxiety. So we have two clinical pictures that are completely different. So this will help us. Second aspect is that we have not to forget that we have a tremendous help by our stethoscope, because the third sound can be heard only if you use the bell. It's extremely difficult that we hear a third sound in an adult patient with the diaphragm. So if we listen everything with the diaphragm, is first sound, click, and second sound. If we listen two sounds with the diaphragm and using the bell, we hear a third sound, that will be the third sound, additional sound, that will be the third. So we can make a good differentiation using the medical picture, the clinical picture, and the stethoscope. If we use these two things together, it's impossible to make the error. Dr. Renan, I hope that I've been clear in this differentiation. Okay.
Clear enough, I think. Yeah.
We can return on this if you like. But again, I want to stress, because this is an important point, because the test was the best modality for me to understand that there is the need to spend time on differential diagnosis. Let's return on this, because Latin usually say old Romans repetita juvant, that in Latin language means more times you repeat, the better it is. So the last time, if you have possibility number one, that is first sound, second sound, third sound, you will have a clinical picture of a patient with left ventricular dysfunction, and the bell will show you the presence of the third sound. With the diaphragm, you will hear only first and second. If you're having the possibility number two, that is first sound, click, and second sound, you will have a completely different clinical picture, and you will have, by the fact that diaphragm will show you all the three sounds. So let's continue now, and we go to the next slide. So this is the slide that I've added, because I realized that this was an important point to be specified. Now we have we are on the mitral area, and we have a very interesting description of first sound, second sound, the click that will appear, and then the pathognomonic sign, that is the late systolic murmur. Because as I showed you before, let's return on the slide for the moment, because it will help us. If we go here, you will see that we have normal movement, prolapse, and regurgitation. If we go slowly, you will see that what happened is, let's ignore echo, and let's go on the magnetic resonance. Let's go here, just one sec. Okay, here it is. So we have anterior wall of the left ventricle, the apex, the inferior wall of the left ventricle, left atrium, and papillary muscle, anterior leaflet, posterior leaflet. If we go step by step, you will see that the first thing that happens is that the mitral valve closer, here it is. And when the mitral valve closes, no regurgitation occurs, but you have to wait a little bit for the appearance. Here it is, here, still no mitral regurgitation. Now mitral regurgitation occurs. So mitral regurgitation, here it is, occurs late in systole, here it is, not immediately, when the prolapse becomes important. So what happens is that the mitral valve closes, the click occurs because of the tension, and then lastly, mitral regurgitation develops. So mitral regurgitation in subject with mitral valve prolapse is a finding that does not occur immediately, but in late systole, as in the papillary muscle dysfunction that I described before. So in the case that I'm going to show you, we have first and second, then here it is, first and second, then click occurs, and then mitral regurgitation and systolic will be shown. So let's see the tracing first, and then we go to the auscultation without tracing. Click now.
Yeah.
Murmur. So we have now the complete auscultatory finding, which is characterized by click plus late systolic murmur. Late systolic murmur is not mandatory because sometimes there is only the click, and then mitral regurgitation years later will develop. And so we can have click and late systolic murmur as a complete mitral valve prolapse auscultatory finding. So let's repeat these, and as usual, I ask you to close your eyes in order to better appreciate the auscultatory findings. So please close your eyes. You will listen first and second, then the click, and then mitral regurgitation, that is end systolic.
Couldn't hear. What? Sorry, the volume slow, so low.
Sorry?
The volume is so low. Could you repeat?
And before was good?
Yeah, before is good. But could you start from the beginning? I will tell you when the volume is low.
Okay, fine. So let me do the following. When something like this occurs, I just want to reload for a moment. Just be patient. I do something that can be potentially useful. Okay, 1 second. Okay, let's repeat the example in 1 moment. Okay, should be this one. Okay.
Okay, clear.
Okay.
Clear. Okay.
Okay, but now we do this with closed eyes because I want that our friends will concentrate on the rhythm, then the presence of the click, and then to the complete finding that implies the presence of end systolic mitral regurgitation. Please close your eye. Okay.
Okay.
Okay. So now we have 4 consecutive, before concluding, 4 consecutive different example of a complete auscultatory finding without preparation. So you will have click and late systolic murmur, click and late systolic murmur in 4 different cases. So this is case number 1. I repeat this case. Please close your eyes. this is the case number 2. Is very similar to the preceding one. Now there are 2 cases that are very similar. The concept is the same, but I want to show you some very sophisticated differentiation. In this case, the click was relatively early and the mitral regurgitation was relatively long. It can occur, like in this case, that the murmur is confined to late systole and is in crescendo, is increasing in shape and in entity throughout its length. So I know that what I'm going to explain you is a little bit, I should not say difficult, but poorly known, because no one pays any longer attention to cardiac auscultation. So these are 2 different patients with mitral valve prolapse. They could seem identical because in each of the 2 cases, there is the click and the late systolic murmur. But now I show you the case that I showed you before, and again this one, without any comment. But in the first case, you will see that the mitral regurgitation has a similar intensity throughout its length. In this case number 2, the intensity of the mitral regurgitation or the murmur will increase progressively. And it is also shown by the phonocardiogram. You will see that is increasing. Look at here. It's like something that goes in this way. It increases. While in the first is constant. So I don't want to make comments in order to avoid to limit your concentration. But I show you again the 2 cases without comments. But please pay attention to the fact that in case number 1, the murmur is constant, even if is in the second part of systole, while in this case is increasing. So let's return to the first one, the one that I showed before. Here it is. So listen and pay attention to the fact that it is constant. You can see and appreciate by auscultation. So let's move to the other one and see the difference. I hope that you appreciate the fact that the intensity is constant in the number 1, is increasing in number 2. So, you know where the difference is? Is that in both cases there is mitral valve prolapse. In both cases, mitral regurgitation is in the second part of systole. In both cases, there is the click, but in the second one is increasing, and this is very likely, of course, very likely, then we have to confirm it by echo, very likely in case number 2, there is a flail leaflet of collapsing valve. When there is a leaflet is flail, that is not uncommon in mitral valve prolapse, is the most severe complication along with arrhythmias. The murmur change is morphology as intensity because the leaflet becomes flail, is separate from the other, and while it's separating from systole, it vibrates as there is increasing velocity and murmur intensity. So this is another last example. As before, it's possible that flail leaflet occur. So summarizing, mitral valve prolapse is a challenging sorry. let me, sorry for this. Let me, okay. Let me close my telephone. This is a friendly interaction. So what I want to explain is that mitral prolapse is a challenging situation, is a very interesting cardiac auscultation arena. And there are so many things that are poorly known that nowadays are becoming more important. It's extremely diffuse, especially in young females. And Dr. Rene, if you like, one day we can spend 1 hour discussing mitral prolapse, not only from cardiac auscultation point of view, but in the overall shape. So I'm ready for question and answer.
Yeah.
Sorry.
Looking forward. Okay. Looking forward for looking forward for another session about prolapse, because we do have so many patients with also prolapse here and also mitral regurgitation, but we do have lots of rheumatic heart disease, as you know, but also there are lots of patients also coming to especially our centers with prolapse fails, and that's variation of the disease. Okay, there are lots of questions also coming from our again, this is some almost similar question, differentiating between the click and with the certain sound and fixed splitting. That's I think
Okay,
last question.
Okay, we discussed
Yeah.
about the click and third sound. The
Yeah.
split of the second sound and the click and second sound cannot take advantage from the clinical picture, because atrial septal defect could be present in a young person, and so the differentiation could be difficult. But
Yeah.
we have to keep in consideration the site of auscultation, because the splitting of a second sound, that means that the pulmonic component of the second sound is perfectly heard, is appreciated on the pulmonic area here, on this, while the click is heard here. So two different situations. So a splitting of the second sound is heard on the pulmonic valve area, while click is betterly heard at the apex.
Okay, this is another question also about, again, in combination of mitral regurgitation and mitral stenosis. Most of patients, have atrial fibrillation. How to easily differentiate systolic and diastolic murmur, and to recognize additional sound in this kind of patient?
Okay, if atrial fibrillation increase heart rate and thus shorten diastole, and thus make the length of systole and diastole very similar, plus there is disorder of the rhythm, I understand that some difficulties can occur. But in the first lesson, I explained that auscultation should start from the aortic area. I show on myself here.
Yeah.
That when you are here, you identify the second sound, and so that is much easier to make a distinction between systole and diastole, and then slowly you go from this area to the apex, keeping in mind the rhythm, and so that you differentiate systole and diastole, and then you will allocate in your mind what you listed in systole and diastole.
Yeah. And it's clear. This is another question about, it's possible to only hear mitral click without mid-systolic murmur. I think you've shown, right? Only click without murmur in the setting of mitral valve prolapse.
Yeah, it's possible.
Yeah, you've shown that, the example.
It's possible.
Yeah. There are lots of questions about opening snap. So there's another. So the next session will be about mitral stenosis, right? Am I mistaken?
No, we covered mitral stenosis last time.
Okay. Again, about the
session will be on aortic stenosis.
Okay,
and
also, yeah.
regurgitation.
Okay, so the again question about opening snap here. to appreciate in the presence of mitral regurgitations and mitral stenosis?
Opening snap is the opening of the valve in mitral stenosis, and is a diastolic finding, is an early diastolic finding, while mitral regurgitation is a murmur and is a systolic finding. So the two situations cannot be confounded because, again, we have a sound, opening snap, and we have a murmur, mitral regurgitation. Opening snap is in early diastole, mitral regurgitation is a systolic murmur. Of course, the two things can be together present if you have a patient that has a mixed valvular disease, like the co-presence of mitral stenosis and mitral regurgitation. This can occur, but you will have the murmur, the second sound, and then the opening snap. The opening snap can be followed by the diastolic rumbling murmur of mitral stenosis.
Yeah, I think there are some 2 or 3 questions about opening snap. I think we have discussed it before, and then again clearly described by Professor Eliseto. Yeah. Murmur is the possible have both mitral and again it's answered. Okay.
I see an interesting question.
Which one?
Between ejection click and
okay.
splitting.
Yeah.
Okay. From one colleague.
Yeah.
So this is interesting because we shall discuss this next time when I shall speak about aortic stenosis, because in the bicuspid valve, the ejection click can be heard. And so you have the splitting of the first sound. On the other end, the splitting of the second sound gives two sounds together, and the ejection click gives two sounds together. The differentiation is based on the site of auscultation, because the splitting of the second sound can be heard on the pulmonic area, while the non-ejection click is better heard in the mesocardium through the apex. There are two different sites of auscultation. In any case, we have in both instances the diaphragm of the stethoscope as the preferred area of the stethoscope to hear these two situations.
Yeah, this is last question is appear here. Is mitral regurgitation and metastasis could occur in the same example? How about mitral valve prolapse? Maybe could it occur in the same example with mitral stenosis? Is it still possible?
Impossible.
Possible because the mechanism is quite different, right?
Impossible because we have two etiologies, different etiology.
Yeah.
Patients with mitral valve prolapse are protected against rheumatic alteration. So the valve with mitral valve prolapse that usually does not go through alteration of rheumatic disorder, for the simple fact that is much more soft, while the stenosis is much more strong. So two different conditions.
Yeah, again, because different condition and different etiology, right?
Yes.
Because we do have lots of mitral stenosis regurgitation, especially in those with patient with rheumatic heart disease, which mostly occur or frequently we found in Indonesia. Okay, I think there are lots of questions already answered. Yeah, I think most of the question we already answered, Professor.
Yeah.
Yeah, I think I would say we already solved of the question, and then we will see you again next session.
Yeah.
So next session would be about
aortic valve disease. We shall have aortic stenosis and aortic regurgitation, and we shall discuss about nice things also next time.
Okay, because this is also very important, because we do have patient also with degenerative, also with rheumatic heart appears or coming with aortic stenosis as well, not only mitral stenosis, or both in combination. We do have lots of patients with mitral stenosis and aortic stenosis at the same time, especially
Next time we shall discuss about these things.
Okay, I think it's up for today, Professor Iliseto. Thank you for your time.
Okay.
Have a
and see you next week.
See you next week, and hopefully my colleagues here get some insight, and then keep learning and keep trying to identify the things, especially the patient, and try do more auscultation, and then how to move the location of auscultation from ABC as you mentioned before. Thank you, Professor Iliseto. I will see you next week.
Sure. Next week. Okay. Bye-bye to everyone.
Bye-bye.
Thank you, Prof.
Profesor Iliseto. Bye. Ya, baik, saudara sekalian, kita ketemu lagi minggu depan. Terima kasih atas perhatian semua, juga teman-teman dari Varia. Jadi kita akan ketemu jam 1 pada minggu depan, dengan jangan lupa memakai membawa atau mengenakan headset atau earphone teman-teman ya, dan silakan post question nanti. Kalau ada yang di antara 2 session yang kemarin masih atau menggantung, silakan ditulis saja dalam bahasa Indonesia boleh ya, teman, dalam bahasa Inggris juga boleh, kita discuss lagi ya. Baik, saudara sekalian, untuk menutup acara ini ada salah satu lagu persembahan kami dari Departemen Kardiologi dan Kedokteran Vaskular FKUI dari acara ulang tahun Departemen 2 hari yang lalu ya. Sekaligus untuk menutup acara ini, terima kasih semuanya, sehat selalu, tetap belajar, dan semoga semua dalam keadaan baik sekeluarga, dan juga pasien-pasien kita tangani semua dalam keadaan sehat. Terima kasih semua, selamat sore ya, salam sejahtera, assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Tanah airku Indonesia,
negeri elok amatku cinta,
tanah tumpah darahku yang mulia,
yang ku puja sepanjang masa.
tanah airku aman dan makmur,
Pulau kelapa yang amat subur,
pulau melati pujian bangsa sejak dulu kala. Belanda di batas terbisik-bisik,
Raja Kelana,
surya di cakrawala,
pulau yang indah bermain,
Indonesia.
bukan lautan hanya kolam susu, kayu dan jala cukup menghidupimu. Tiada badai, tiada tempat kau temui, ikan dan udang menghampiri dirimu. Hidup di pantai, berbisik-bisik, Raja Kana bersatulah semua.
Dari sebuah kecintaan akan gagasan, gairahkan semangat untuk bekerja keras. Lahirkan karya bermutu dan berkualitas tinggi. Dari setiap detail inovasi yang dilakukan, yang mampu hidupkan mimpi. Hadir nyata melintasi masa, membentang ke penjuru negeri, yang membawa perubahan berarti di dunia farmasi. 1976, Daria Varia resmi didirikan sebagai perusahaan farmasi. 1978, menjadi produsen pertama kapsul gelatin lunak di Indonesia. Dan di 1994, terus berkembang menjadi perusahaan terbuka. 2001, berafiliasi dengan perusahaan farmasi terbesar Filipina, United Laboratories Incorporated. 2012, mencapai angka penjualan sejumlah 1 triliun rupiah. 2016, di usia 40 tahun, Daria Varia tetap berkomitmen untuk Indonesia yang lebih sehat. Daria Varia berdiri teguh di bentang industri farmasi Indonesia. Menghasilkan produk berkualitas melalui 2 manufaktur kelas dunia yang berada di Gunung Putri dan Citerep Bogor. Pabrik Gunung Putri menghasilkan produk kapsul gelatin lunak, cair, krim, dan lotion. Dan pabrik Citerep memproduksi produk injeksi steril dan sediaan padat. Semua produk diproses sesuai cara pembuatan obat yang baik, didukung oleh teknologi yang modern, dan sumber daya manusia yang kompeten, profesional, dan ahli di bidangnya. Pengembangan fasilitas pembuangan limbah merupakan wujud nyata kepedulian kami terhadap lingkungan. Kami sangat memperhatikan kualitas bahan baku, proses produksi, quality control yang ketat untuk memastikan produk yang berkualitas tinggi hingga ke tangan pelanggan. Fokus kepada kepuasan pelanggan menjadikan Daria Varia dipercaya memproduksi produk berbagai perusahaan-perusahaan farmasi lokal maupun multinasional terkemuka dan mengekspor produknya ke berbagai negara di ASEAN dan Timur Tengah. Daria Varia untuk Indonesia yang lebih sehat.
Terima kasih Dokter Renan.
Terima kasih Dokter Rena.
Oke, terima kasih semua. Terima kasih teman-teman. Sampai ketemu minggu depan ya.
Sampai ketemu minggu depan, Dok.
Terima kasih.
Dokter
Terima
Sasa.
kasih.
Renan. Salam sehat, Dok.
Oh, sehat semua, sehat. Merdeka.
Sinaga.
Sukses,
Kapan
Dok,
nyanyi?
ya. Masih
Sukses.
ada 2 series lagi. Thank you, ya, Dok.
Mantap, mantap,
Iya, semangat.
mantap. Tinggal kita nyanyi aja nih. Mana lagu
Iya.
Pak Sinaga?
Kalau acara
Oke.
tidak virtual, kita udah pasti nyanyi, Dok.
Nyanyi kita, mantap.
Thank you,
Oke,
Dok.
sampai ketemu minggu depan ya.
Ya,
Yuk,
sampai ketemu,
terima kasih,
Dok.
bye. Yuk.
Bye.